this here. Yeah. Okay, this is exciting. Before we start, I'd like to ask if you can raise your hand if you've heard of community-led monitoring. Raise it high. Now, keep your hand raised if you are implementing or if you have experience previously implementing community-led monitoring. Raise it really high. We want to see. Perfect. Hey, nice. Well, before we get started, I wanted to just provide a little bit of context. Community-led monitoring is not new. It is an approach, it's a process that goes by many names: social accountability, community-based monitoring, perhaps. And we've done it in our countries for many years. Good governance activities. It's really at the core about giving voice to the end user. And the one aspect that really differentiates community-led monitoring from just monitoring or evaluations, site visits, SIMs. We've gotten a lot of questions. Isn't it just SIMs? No, it's not. It's truly community-led. It's about ensuring that the users, that there are people affected by HIV/AIDS, really have a voice, not only in holding accountable and ensuring that they are able to communicate what they expect the quality of the service that they're receiving should be, but they're also actively participating in providing solutions, working together with service providers. Community-led monitoring is not a watchdogging activity. We hear that a lot from some partners. It's a watchdog activity. It's only about holding service providers accountable. What we do want to distinguish, and you'll see it in the PEPFAR guidance, is that it isn't just about holding them accountable, it's about helping them. It's about working alongside service providers, providing evidence-based barriers. Like, what are the actual barriers that we're facing? What does the data tell us? That the barriers that we're facing for access to care, for retention. But also the communities generating solutions and working together with service providers and other stakeholders to identify workable solutions and then monitor the impact of those solutions. So therefore it is community-led. It is not just a one-time activity. You can't just present a report and walk away. It has to be a process that is repeated and routinized and cyclical and builds on itself. And before we hear from our distinguished panelists, I also just want to say that it doesn't only have to be restricted to HIV. That's something that we are hearing also in the global community that is supporting and advocating for more CLM, and not just more CLM, but better CLM, that it can be applied across diseases, because at the end it is about quality of care. So it could be TB, malaria, and we're going to be hearing some examples of this. So without further ado, we are going to be listening to colleagues from the Kyrgyz Republic, Tanzania, and Burkina Faso. I know many times when we talk about in PEPFAR with CLM, we always hear about South Africa and the great activities here in Mozambique and Uganda, and we're very excited to learn from them because they are doing some incredible work. But there is incredible CLM happening in many places, and we want to hear from them. So today we're going to hear from Dina Masalimova from AFU, Kyrgyzstan, Raga Balea from Korab, Burkina Faso, and Matthew Kawogo from Nakofa, Tanzania. So it is really my pleasure to introduce Dina.
Good afternoon. It's my pleasure to be here and to be able to present our experience of work under the CLM. We have started just a year ago, so we are very new, and I can't say that we have that much of experience, but we were the first CLM activity in Central Asia, the first CLM activity in the region. So this year has been very exciting for us, and we have learned a lot along the way, something that I would like to share with you. So this first slide is just to give you some context about where I'm from, because I'm sure not all of you have heard about Kyrgyzstan. We are a country in Central Asia with 7 million population. We are a small country. And on the slide, you can see the scale of the epidemic. So it is estimated that we have 10,000 HIV cases, and so far we have diagnosed almost 80% of them, and we have some gap between the people who are diagnosed and the people on treatment. Only less than 70% of the cases who are diagnosed are on treatment, and the viral load suppression rate is about 90%. And in the past few years, we have seen a lot of changing trends in the epidemic in the country. We have seen that the driving force of the epidemic has been changing. It used to be injecting drug use, but it's no longer the case. We used to have a large proportion of males who get infected, but this is also not the case. So it is very important that the CLM activity in the country has started, just to make sure that the services that are provided within the PEPFAR services are actually what the beneficiaries really need, that they are in sync with the trends in the country, and that they are acceptable and accessible for those who need them the most. So, as I have already said, we are the first CLM activity in the region, and we will be working for 3 years. The first year has already passed. We work in order to collect, analyze, and utilize the community feedback on the peer-to-peer basis in order to use it to further improve access to services, the quality of services, and the health outcomes for the HIV services beneficiaries in the country. And our scale is not very big because we are a pilot. In our first year of work, we monitored 4 organizations, 4 service providers. And in the coming years, we plan to monitor 12 more. I keep saying we, but I want to define who we actually are. So on this slide, you can see the structure of our team. Our team, the core members of our team are 3 CLM experts who represent the 3 key populations: people living with HIV, people who inject drugs, and LGBT community. And they are the people who are in charge of everything within the project. They make all the big decisions, starting from what information to collect, how to collect it, where to go with this data collection, what tools we are going to use, what our priorities are in terms of data collection. So after these big decisions are made, they are the ones who go to the community sites in order to collect information, in order to speak with the beneficiaries, and then come up with the recommendations and communicate the findings to the sites that we have been monitoring. And it is not enough to engage just with the sites, because sometimes the recommendations are really small, like, hey guys, you need to put a poster with the contact information of those who people are supposed to contact in case of human rights violation or any other problems. And in this case, of course, this can be solved at the site level. But in many cases, we need to go up in order to help the organizations to solve the problems that they have. And we are very happy that we have the donor level partners on board with us. We have the major USAID and PEPFAR implementing partners, EPIC and ICAP, who are there for us and who have been very responsive in terms of the problems that we are communicating to them, like the capacity building areas, like some budget changes, indicator changes. We have seen this happening thanks to the responsiveness of the donor level. But sometimes the recommendations are even higher than that. Like, let's say we have seen a lot of migrants who lack access to treatment, to ARVs, to PrEP, and to other medications when they go abroad to work, because we are the country who is exporting migrants to the nearby territories. So for this case, we are closely working with the CCM, and we make sure that all the findings we make are presented at the decision-making level. Next. So on the slide, a very brief overview of our findings for the first few months of work. First of all, it's important to say that the feedback from the beneficiaries has been very positive. And basic HIV services like testing, like counseling, are highly accessible and acceptable in the country. They are provided in accordance with all the national standards, and the level of beneficiary satisfaction with the services is very high. We have recorded no interruptions or stockouts with the supplies like medications, like condoms, lubes, and etc. But of course, we have seen some gaps as well, and I have also listed them on the slides. And the one that stands out the most is that the PrEP awareness level in the country is low. It is not enough to fully roll out the program in the country. And we have seen it in the beneficiaries and among the healthcare providers as well. And there are also some legal barriers that impede access to PrEP in the country. Another problem that really stands out is it goes beyond HIV. It is about a variety of complex problems that the beneficiaries are facing, like addictions, like poverty, gender-based violence, lack of ID documents, and we see that these problems are not addressed enough, neither by PEPFAR at the moment, nor by other major actors in the country. And of course, women suffer from this much more since we live in patriarchal society, and gender-based violence is a big problem, and women rely a lot on men to make key decisions about their health, about PrEP, about ARV, and etc. And last but not least, migration, something that I have already mentioned, that we need to work in order to improve access to treatment and to PrEP for those who go out of the country in order to work. And our guiding principles. So we are community-led at all stages. As I have already mentioned, all the key decisions that are made within the project are made by the community experts, by the team who represents all the key populations in the country. Another guiding principle for us is that we decided to go for the quality data collection. As I have already said, the scale of the epidemic in the country is not very big. And when we break down the number of the beneficiaries by site, we see that it's not a lot per every site. So we think that it's one of our key difference that we collect the data directly from the beneficiaries, that we offer that ear and we can listen to whatever the beneficiaries have to say, and that we make sure that their opinion, their voice really counts in terms of making decisions about service delivery at every site. Another issue that might seem a little bit obvious, but it was crucial for us, it was to describe the achievements and gaps fairly and objectively. Why I'm mentioning this is because as we decided to go with the quality data collection, in the beginning we have seen human factor affecting some of the reports, both from the beneficiary side and from the side of our experts. And when you implement an activity like this, when you want to really make some impact at the country level, at the national level, it is very important that all the data is fair and that it is really objective. We also make sure that we are on the same side with the community sides, that we are there to voice their problems to the decision makers, to help them to optimize their problems, and that we are not just the auditors who came to find some flaws within their work. And last but not least, no reports for the sake of reports. It means that we want to make sure that all the recommendations that we make are really feasible, that they can be implemented without tremendous amount of extra efforts or resources, and that we make sure that we follow up with our recommendations and that we help communities to solve the problems that we have heard about during our monitoring visits. So thanks a lot.
Great, thank you so much, Dina. And we're just going to wait. Actually, Raga, Raga will be presenting in French, so we hope to have some headsets for those of you who would like to be able to follow along. If it is okay, perhaps Matthew can go next, and then as we share out the headsets for our for our participants, we'll then return to Raga's presentation. Excuses for that. So we'll just, sorry, and then we can go back.
Thanks, Mike. I'm Matthew Kawogo, as Mike said. I'm coming from Tanzania. I'm working with the National Council of People Living with HIV in Tanzania as the manager for private sector and community engagement. And I'm also coordinating the National CSO platform for community-led monitoring implementation in Tanzania. NACOFA, the National Council of People Living with HIV, is a grassroots organization working with people living with HIV and key populations, but also engaging the government and implementing partners in ensuring that people living with HIV are becoming at the center of service delivery in Tanzania. We are presented in all the councils of Tanzania, 184. We have structures and representation of leadership of people living with HIV. And we are growing. When we started in 2005, we were very few, around 150. But currently, we are over 600,000 in the country, bringing together people living with HIV to lead the implementation of HIV services at community level. Today, I'll talk with you about community-led monitoring, and Mike has given a very good definition. But to the large extent, our approach is actually looking into the implementation and monitoring of 5 A's: the availability of services, accessibility of services, acceptability by people living with HIV, affordability, and also appropriateness, looking into issues of gender, age, and also key groups like people living, key and vulnerable population. So, this is our approach. Of course, the guiding principles, the Denver principle, which focuses on ensuring eradication of discrimination. This was it was in 1983. It happened in Denver. So, but also the principle around meaningful involvement of people living with HIV, ensuring that we are not just bringing numbers into services, but also ensuring that they are forming part of decision-making and monitoring accountability of HIV services. We are also guided by the National Quality Improvement Framework of Tanzania government and the Community Quality Improvement Framework, which says people living with HIV, and particularly service users, will be the third eye in ensuring that we contribute to the improvement of quality of services. And lastly, Tanzania government has the national service delivery models as a guideline to ensuring people living with HIV are at the center of service provision. In terms of strategies to engage, it is based in 3 levels. The government was involved during the entry meetings to ensuring that we build common understanding of what CLM is, that we are not actually policing, but rather seeking our voice and participation in monitoring accountability of services. But also people living with HIV, we make sure that they are engaged from the onset, designing phase, but also developing and the utilization of the tools. And also we engage our colleagues, the civil society organizations, in terms of training, review of the tools, and particularly sharing the findings coming from community-led monitoring for them to support the implementation of the findings. This is the approach. As I said, during tool development, we ensure that we went through other experiences from other countries. So we did a desk review, and of course, we had a group of meetings at the community level to ensure that development of the tools is gaining the participation of people living with HIV, the service users. We went on to pre-test the tools and started with a pilot in 4 councils in Tanzania. And then we improved the tools based on the experience from the pilot before starting engagement of the local government authorities for the entry meetings, which I said earlier, to ensure that we are in the common understanding of the approach and processes. Then we went on to train community data monitors, the service users themselves, on how to collect data and participate in the analysis of the information. Then provide feedback to the council health management team and regional health management team on the findings which are coming out of the community monitoring process. Then through the engagement with the government, the decision makers, that's where the action plans are developed, the joint action plans which bring together participation of the government officials who are responsible for HIV/AIDS implementation. And also we have responsibility within the plan for the implementing partners and also people living with HIV themselves to make sure that we do a quarterly monitoring of what has been agreed, that if we find this problem, then we are monitoring in a period of 3 months to make sure that what we agreed during the action plan setting is actually implemented, or if it's not implemented, then we come again in the table with decision makers and health staff to make sure that we address the challenges coming from the community in terms of service utilization. These are the tools that we are using. We actually have 2 questionnaires, one for service recipients, and the other one is to collect information from health facility to ensure that we do triangulation and see how we work together in monitoring what is agreed. The analysis, we are using the COBO tool, and then we export information to Excel for further analysis. And to date, this is the coverage. We have managed to reach 183 facilities from 38 councils of Tanzania, and we have trained 380, 10 per council, people living with HIV to collect data. And we have reached 366 staff from the health facilities, and response from people living with HIV who are using services has been obtained from 3,689 people. Currently, there's monitoring of promised changes which is going on at council level, and we have a plan to continue engaging IPs in terms of ensuring they are also participating in addressing the challenge. This is an example of some of the findings, and the most peculiar one is we have problems in terms of, in some councils, we found out that the turnaround time for HIV viral load testing is taking long. So in a process of engagement, this challenge needs to be addressed at national level. So there are some issues, as my colleague said, that cannot be addressed at community level. And we are happy that the government, we provide the advice through CLM that we have gene expert machines which are testing in TB. They can also be converted to provide HIV viral load testing. And out of 142 machines in the country, the government has already converted 43 machines to increase the number of machines which are providing testing for viral load, and hence reducing the turnaround time. We also have challenges around missed appointments, and we have set a mechanism at facility level to remind service users through mobile phones and text. And also in terms of increasing access to HIV testing services, we worked with the government and facilities, and now we are experiencing an increase in terms of number of facilities which are providing outreach services. And to address stigma, we are doing outreach with the government staff to provide training at site level to health staff. We have plans to use the data, particularly on systemic change, in terms of ensuring integration of CLM data into the government is now having a unified community data system, and we have started discussions with the government of Tanzania through the Ministry of Health to include CLM data into the unified community data system, but also advocate for the review of national guidelines, particularly the quality improvement frameworks, and ensure that it includes community-led monitoring as one of the approaches to improve quality of services. We want to influence recognition and participation, the meaningful involvement of people living with HIV. So we expand our work to more facilities. We are currently in 65 councils. Through this year, we'll reach the remaining councils and ensure the coverage of CLM is bigger and brings the required responses. This is a picture. The first one is the engagement of people living with HIV to review the tools. And the other one is the team of NACOFA staff incorporating inputs from service users into the tools we are using currently. Thank you.
Thank you so much, Matthew. Now we're going to hear from Raga. We are going to have live translation, so that should facilitate things. Sorry for for the small hiccup. Right, Raga, please. Thank you.
Ok. Merci. Donc, je me nomme Valéa Raga. Je suis donc ok.
Thank you very much.
Ok. Donc, j'ai le plaisir de partager avec vous ce soir notre expérience, celle de la CORAB, qui est la coalition des réseaux et associations burkinabés de lutte contre le VIH et de la promotion de la santé au Burkina Faso. Notre approche donc part de la mise en œuvre de suivi communautaire des services VIH dans les sites soutenus par le PEPFAR au Burkina.
We are going to talk about CLM in the PEPFAR sites in Burkina Faso.
Et moi qui me fais le plaisir de vous les présenter, je m'appelle Valéa Raga, j'assure donc la coordination de ces projets au sein de l'association.
And my name is Valerian Iga. I'm at the coordination of the project in the association.
Okay. Il faut dire que c'est au moins plus de 20 ans d'expérience donc, dans le domaine du VIH, de la santé de la reproduction, qui m'a permis donc d'accéder à la CORAB où je suis donc beaucoup plus impliqué dans le plaidoyer, mais aussi la veille communautaire.
So I have an experience of more than 20 years in that field, and now I'm at the advocacy level.
Okay, donc, alors, je vais simplement aller droit au but pour dire que la mise en œuvre du suivi communautaire des services VIH dans les sites soutenus par le PEPFAR part donc du constat qu'il y a des insuffisances, mais aussi des dysfonctionnements et des barrières, et cela malgré donc les efforts consentis, aussi bien par notre pays que ses partenaires, pour faciliter donc l'accès des personnes vivant avec le VIH aux services de qualité. C'est trop long et trop rapide. Bon, alors... Désolé, je crois que si la prochaine fois l'occasion m'était donnée, ça sera en anglais.
Next time, I will do it in English, I promise.
Ok. Alors, je reprends pour vous ou on continue?
Rewind.
Ok. Alors, il faut dire que notre approche donc, combine plusieurs méthodologies.
So we have different methods that we apply.
Elle s'est faite donc surtout sur la base d'une collecte digitalisée des données.
And we do it on the basis of a digital collection of data.
Et pour ce faire, donc, nous utilisons trois principaux outils.
In order to do this, we use three main tools.
Le premier porte donc sur la satisfaction des clients dans les
First,
sites
customer
PEPFAR.
satisfaction.
Le second consiste donc à collecter les informations programmatiques, les informations de routine auprès donc des chargés de suivi éval des sites soutenus par le PEPFAR.
Data collection through interviews with the PEPFAR agent on the fields.
Et la troisième méthodologie que nous utilisons donc c'est le client mystérieux qui parcourt donc le circuit du patient dans les sites soutenus par le PEPFAR. Il observe et collecte les informations.
And then we have an anonymous client that goes through different sites in order to collect data.
Ok. Donc l'ensemble de ces informations sont dépouillées, elles sont traitées, elles sont documentées.
So we collect this data, we analyze it, we document it.
Et nous avons donc un comité de suivi donc, des mesures correctrices qui tient ses sessions chaque trimestre, qui analyse donc les dysfonctionnements et les barrières relevées.
And
Et
we have
donc,
an M&E committee that meets quarterly in order to analyze the data.
et adresse donc par conséquent les solutions idoines aux responsables des sites soutenus par le PEPFAR qui ont la charge de mettre en œuvre les recommandations qui y émanent.
And then recommendations are made regarding this data.
Alors, donc, je crois que je vais économiser le temps en allant directement donc, à l'essentiel.
I will try to be straightforward.
Comment nous utilisons donc les données du CLM pour modifier nos programmes
So how are we using the data in order to shape our programs,
et dans l'optique d'avoir un impact à l'échelle nationale du Burkina?
in order to have a national impact?
Nous pensons que à travers les données que nous avons, nous pouvons interpeller les décideurs et les acteurs
Through the data that we have, we can talk to the decision makers
sur les entraves donc, à l'effectivité des droits des populations
concerning the human rights violation,
et les pratiques donc, de stigmatisation et de discrimination,
stigma and discrimination,
sans oublier donc, les violences basées sur le genre.
without forgetting gender-based violence.
Nos données devraient également nous permettre
The data can allow us
d'assurer donc la veille citoyenne pour la suppression effective, d'assurer la veille citoyenne pour la suppression effective
to monitor citizen monitorship
des frais formels et informels
of informal and formal
que les personnes vivant avec le VIH paient dans les sites.
for the patients and the people living with HIV.
Alors, nos données devraient nous permettre également de mettre à la disposition des acteurs
The data can allow us to offer to different
l'information,
stakeholders data,
l'information stratégique
strategic data,
pour la prise de décision, notamment au niveau donc, de la partie gouvernementale,
for decision making at government level,
et assurer également le suivi et l'évaluation des mesures correctives
and for the M&E of collective.
Elle devrait également nous permettre de faire le plaidoyer
It allows us to conduct advocacy
pour l'effectivité donc des droits en matière de santé à l'endroit des populations clés et particulièrement aussi à l'endroit des groupes spécifiques. Wow. Bon, ok. Alors, elle devrait donc nous donner,
This can allow us
voilà, devrait nous permettre donc d'entreprendre des actions de plaidoyer
to conduct advocacy
pour l'effectivité des droits
for the efficacy of rights
en matière de santé
concerning health
au profit donc des
for
populations,
key population,
y compris donc les groupes spécifiques.
including
Ok.
specific groups.
Alors, elle devrait également nous permettre donc d'assurer la veille proactive
This helps us
Pour-
for the monitoring
oui, pour la résolution de toute situation conflictuelle,
of conflict resolution
de violation des droits,
and human rights violation
d'accès à la santé.
regarding access to health.
Voilà. Et à l'échelle nationale, nous pensons que nous allons travailler à étendre donc le suivi communautaire
And on a national scale, we would like to spread monitoring and CLM.
Alors, qu'est-ce qu'on peut retenir donc de la mise en œuvre de CLM au Burkina?
So what are the outcomes of the CLM implementation in Burkina Faso?
Après un an de mise en œuvre, entre avril 2021 et mars 2022,
After a year of implementation between April 2021 and March 2022,
nous avons pu donc documenter des cas de dysfonctionnement
we have documented a few cases of dysfunctionalities,
notamment des ruptures d'intrants
such as stockouts
pour le dépistage,
for testing kits,
mais aussi pour les ARV au profit donc des personnes vivant avec le VIH.
as well as ARTs for people living with HIV.
Et à ces propos, je dirais que ça fait un total de 4 cas de rupture que nous avons notés dans 4 sites.
And we have seen 4 cases of stockouts in 4 different sites.
La collecte des informations nous a permis également
Data collection also allowed us to
de noter donc des cas de frais formels payés par les patients.
detect informal fees that have been paid by patients.
Et nous retiendrons à cet effet que 11,15% des personnes vivant avec le VIH interviewées
And we have seen that 11.15% of people living with HIV that have been interviewed
ont déclaré avoir déboursé de l'argent pour les services offerts,
told us that they paid for the service that were offered,
ce qui n'est pas normal
which is not
parce que notre
normal.
pays a adopté des textes
Because we have voted laws
qui consacrent la gratuité de ces services-là.
for free care.
Nous avons également donc pu noter à travers donc le CLM
And through CLM, we have noticed
que l'application donc du test intrut
The application of test and treat.
est effective donc dans les sites qui sont soutenus par le PEPFAR
It's effective in the PEPFAR sites,
et que 4% donc des personnes, et là c'est sur la base donc des données de routine, 4% des personnes dépistées séropositives
that 4% of people that have been tested positive
ont été mis sous traitement immédiatement.
were initiated to treatment immediately.
Alors, on va aller rapidement. Au niveau de la dispensation multimois, puisque nous cherchons également à documenter cela,
So for the multi-month distribution,
39% donc des personnes vivant avec le VIH
39% of PLHIV
et qui ont été interrogées
interviewed
ont déclaré bénéficier donc des ARV pour 3 mois au lieu de 6 mois.
said that they benefited from ARVs for 3 months instead of 6.
Oui, et elles sont au nombre de 47,8% celles qui ont la dispensation pour 6 mois.
47.8 have been given medicine for 6 months.
Pour ce qui concerne donc la transition vers le TLD,
And for the TLD transition,
c'est une réalité au Burkina Faso.
it is a reality on the ground in Burkina Faso.
Mais le comité donc thérapeutique a décidé de passer de façon progressive à la mise sous traitement TLD des différents patients des files actives.
So the Health Council has decided that there will be transition to TLD.
Ok. Nous avons pu également donc noter des cas de stigmatisation.
We have seen a few cases of stigma,
Et sur 339 personnes vivant avec le VIH qui ont été interviewées,
and over 339 people living with the HIV that have been interviewed.
4 ont déclaré avoir éprouvé
4 declared
un sentiment de stigmatisation
that they felt stigma
ou de discrimination
and that they have been discriminated against
de la part des prestataires de santé.
from the health personnel and staff.
Mais je veux ajouter que le CLM au Burkina
I want to add that CLM in Burkina
fait également donc le plaidoyer pour maintenir le niveau de financement du pays en faveur du VIH.
is also conducting advocacy in order for the financing for HIV in the country.
Et dans ce cadre, donc, nous avons pu obtenir donc des autorités qui étaient démocratiquement élues
And we have been granted from the authorities
une augmentation de 19% donc, du budget de 2022 comparativement à celui de 2021.
a raise of 90% in the budget if we compare it
Oui,
to
mais-
2021.
Mais force est de reconnaître que les récents remous donc, du pays ont mis à plat cet acquis.
But we have to acknowledge that the situation in the country have put us back to square one.
Alors, je m'en voudrais donc de présenter nos résultats ici sans parler des défis de notre pays qui sont spécifiques.
So I shouldn't talk about the results without talking about the challenges that are quite specific to our country.
Oui, le Burkina Faso connaît donc des fermetures de ses formations sanitaires dans les localités à défis sécuritaires.
First of all, we have a few health centers that have been closed down because of security reasons.
4 des 13 régions administratives du pays sont sous menace terroriste.
We have
4 sur 13.
4 out of 13 in the regions are under terrorist threats.
Ce qui rend donc beaucoup de zones inaccessibles
So there are a few areas that are not
pour la
accessible
collecte des données par certains agents,
when it comes to data collection from
mais
the
aussi,
agents,
mais aussi pour les personnes vivant avec le VIH, donc de pouvoir avoir les ARV.
but also for people living with HIV in order to have access to treatment.
Donc malgré tout, nous avons décidé donc de maintenir nos activités
So despite the fact that we carry on our activities,
et tout en essayant de ne pas mettre la vie des agents de collecte en péril.
we are trying not to endanger the life of our agents on the field.
Alors, je crois que au regard du temps qui nous est imparti,
Because of time constraints,
nous sommes allés donc à l'essentiel
we have just mentioned the strict and the bare minimum.
et nous vous remercions donc pour l'attention que vous nous avez accordée.
And we would like to thank you for the attention.
Merci.
Thank you so much, Raga. And one really great round of applause for our presenters. Now we would like to open it for questions. We do have some mics that we can share. And yeah, we only have about 12 minutes left, but because it is the last session, maybe we can go a few minutes over, given some of the delays, if you will permit us. But yeah, let's hear some questions, please. And if our translator can return to the front, just if any questions are asked of Raga, apology.
Thank you.
Or if anyone else who could be a translator with her.
Yes, the mic is working. Okay. So thank you very much. I'm Dr. Hortense May, Senior Health Advisor, USAID West Africa, based in Togo. So I have two questions. My first question will go to Matthew. Should I move there? Okay. Again, thank you to all of the presenters. It was really helpful and very wonderful for the work that you are doing at the field. So for Matthew, I saw that you have some question to the health workers when you present. So sometimes for the CLM, we used to ask questions to the beneficiaries. When you were presenting, you said that you have questions to the health practice. So I want to be curious to see what kind of question do you ask and what do you use with this answer? Because sometimes in the term of improving the quality of services, we ask more questions to the beneficiaries and we try to improve in this way. So this is my first question. My second question will go to Korab, Burkina Faso. Should I say in English or French? Ok. Alors, la Korab, je voudrais que vous puissiez nous dire aujourd'hui, après un an d'exercice, avec les difficultés du début et ce que vous voyez aujourd'hui, qu'est-ce que vous pensez que le CLM a permis d'apporter de plus au Burkina Faso et quelles pourraient être vos perspectives pour le prochain COP pour améliorer la qualité des services? Merci. Okay. So, my question to Korab is, after 1 year of implementation, what are the success and the lesson learned that they can share with us from, because at the beginning they were facing a lot of challenges. So now after 1 year, what are the lessons learned? And for the next COP, what are the strategies or which way they want to go? Thank you.
Thank you so much. I think we can answer these questions first, and then I'll collect some more. Yeah, go ahead, Matthew.
Thank you so much. Why are we asking questions to health staff? Because it is important also to hear the other side of the story. If we base on feedback from service users only, sometimes we will be biased with the approach that we want to be put in place by the government. But also, people living with HIV in Tanzania are advocates of service providers. There are concerns which, if we don't speak to the government, they want to be addressed. So we have specific questions, for example, quantitative data on stocks around ARVs, PrEP, but also information around how they are addressing stigma and also concerns also from service users. We want to hear them, what do they say? A sort of triangulation, but in most cases it's about hearing them so that we can propose appropriate measures, particularly for the issues which needs to be addressed at national level by the Minister of Health. Thank you.
Thank you, Matthew. And for Raga's response, I'd like to ask if we have someone who can translate. This is a community-led session. We will be asking the community support, so please. Yes. So if I can hand that microphone to someone who can support us in the response.
I will try my best. Okay. Valéa, tu peux y aller.
Yeah, you can use that.
La question qui m'a été posée est de savoir qu'est-ce que le CLM apporte au Burkina Faso, quelles sont les leçons donc, apprises. Il faut dire que le CLM contribue énormément donc, à améliorer l'offre des services donc, de santé dans les sites.
CLM has contributed to improve a lot of the quality of services provided on HIV.
Et à améliorer par là également donc, l'accès donc, des personnes vivant avec le VIH, y compris surtout les populations clés aux services qui leur sont offerts.
Improve really the access of services, especially for the key population.
Donc pour nous, le CLM est un outil donc d'aide pour les sites soutenus par le PEPFAR afin d'être plus performants.
So CLM is a kind of tools for PEPFAR implementation to have a better performance.
Ok. Alors, en ce qui concerne donc les leçons apprises de la mise en œuvre du CLM un an après à son début, il faut dire que le CLM est un moyen au service donc, des communautés pour s'assurer par elles-mêmes de leur accès aux services de qualité.
Okay, so lesson learn one, the CLM is a tool for the community themselves to be sure that they have access to the HIV services.
Oui. Mais pour nous, en tant qu'acteurs de la société civile, le CLM est un outil qui permet donc de disposer des évidences en termes de données, mais aussi des arguments de plaidoyer pour améliorer les services de qualité à travers des actions.
Pause. So, as a civil society, CLM is a good tool for us because we have an evidence, the proof of what is really, and then we can use it for advocacy and plaidoyer.
Oui, plaidoyer pour en fait améliorer voilà, l'accès des populations aux services.
Okay, and they can use it as a tool for advocacy to increase the accessibility of HIV services to the beneficiaries.
Et enfin, en ce qui concerne donc la partie gouvernementale, le CLM est un outil d'aide à la décision.
Okay. And the last part for the government, the CLM is a tool for decision making for the government.
Et non pas donc un outil de dénonciation.
Okay, it's not a tool that they use to, how you translate it? Say, please, can you help me somewhere? Okay, thank you. It's not a whistleblower tool, but it's a tool to use for advocacy to the government. Thank you.
Voilà, parce que l'État est un partenaire et nous travaillons en complémentarité. Le plus important, donc, c'est comment offrir des services de qualité aux personnes vivant avec le VIH. Okay. Chacun joue sa partition.
Okay, because the government is also a partner, the game is to play together to have good results. So the best point for them is to use this tool to do advocacy and to still work together with the government. And then they have the same goal. This is the access of services and quality services HIV for persons.
Merci.
Thank you.
Thank you so much. Community in action. Thank you so much. Another question? We have, I know we have a question here. Well, we'll do four. Yeah, we'll just do the 1, 2, 3, 4, 5. So, if you can permit me, please.
Thank you. I'm Banele Nkambule from World Vision Eswatini. I'm interested to understand more on the approach from my colleague from Kazakhstan. She indicated that they work with 3 experts or 4 experts that do the monitoring. But I want to understand in terms of the community-led monitoring approach that they use. Are they using any reference documents? Are the people that are being monitors, are they involved in terms of the monitoring tool development? Something like that. I want to get more understanding on that. Thank you.
Thank you. My name is Alice Yuki. I work with World Vision Kenya. Yeah, I listen into CLM, and it aligns very well with what World Vision call Citizen Voice and Action. Yeah, and I know in Citizen Voice and Action, the interface platform, where the team that is collecting data and the service providers like the CHMT, when they have the dialogue based on the results of the data that is collected, then that really informs service delivery or what needs to be improved. My question is on the team that is collecting data. I believe that is people living with HIV. And so it means it's community workforce or volunteers that is taking lead. From the presentation of Tanzania, I realized that your plan is to advocate with the government to integrate this into the health program. As we speak, what are you doing to ensure the sustainability? Because these are community structures that we are working with. So what are we doing at the moment to ensure the workforce is motivated? Do we remunerate them to do this? But what are the sustainability mechanisms? Thank you.
Okay, so about the CLM approach in our country, as I have said, we only have 3 CLM experts who represent various communities, and they were involved in creating the tools. We have 2 tools for data collection. One is the guide for in-depth interviews with the beneficiaries. We go through all the services that are provided at the site level. And in order to make the beneficiaries understand what the service should look like, we have a set of questions with a yes or no answer. For example, regarding to testing. Did you receive pre-test counseling? Was it given in a friendly manner, in an understandable manner? Did you develop the plan for risk reduction? Who performed the test itself? Was it the same person? Was it done confidentially, and etc.? So that the person understands what the service should look like. And after that, we ask our beneficiary to rate the service from 1 to 10 to make sure what his or her level of satisfaction with the service is. Of course, when we came up with the tool, it was not perfect. So throughout the implementation of the project, we tried to amend it to make it more understandable, to make it more appropriate for the beneficiaries. So this is the first tool. And the second tool that we're using is healthcare professionals and a community-based staff, community-based organization staff questionnaire. So as was already mentioned by the colleagues from the panel, we also want to hear the other side of the story, and we want to make sure that the data we collect is very comprehensive. When it comes to the decision-making process, of course, we do make sure that the communities are also involved, because after we provide the action plan and the recommendations, we come with the follow-up visit, and we go through the same questions with the beneficiaries again to make sure that their satisfaction level with the services increased. And if it has not, we are asking for the reasons why. Maybe the plan that we came up with needs to be amended. Maybe we need something else to be done to make sure that the service really works for the users at the particular site. And to make sure that we don't use one-fit-all approach, because at each site level, we have various groups of beneficiaries, various age groups, various KP groups, and we make sure that the actions that we recommend are suitable and that they are tailored to the needs of each individual beneficiary group. I hope this answers your question.
Thank you, my sister from World Vision. Glad to hear from you. I remember when I was working with World Vision around 15 years back, we had a document which is called As We Walk Together, and it talks about the core values. And one of the core values was we value people. The concept around participation and bringing communities to the ground, talking and getting what they know, and to teach us how we do things. NACOFA, the National Council of People Living with HIV, has established structures at community level. We have structures in 184 councils, and we have over 200 ward-level structures. And we have groups of people living with HIV. The organization itself is formed by members from these groups. And one of the principles of establishing those is the voluntary spirit that they have, and understanding that seeking colleagues to access services is one of the prime functions. So apart from the incentives we are providing currently, we are grateful to USAID for supporting the project and providing such incentives on a monthly basis. but also we are building the sustainability aspect in terms of the structures will be there forever, even if the project ends. And understanding that we need to meet our colleagues, our family members, and taking them to services is a key function of the structures. So we believe at the end, this will be continuing. But also we are engaging the policy review. We want this to be led and implemented through the government resources. So recently we participated in the review of the National Multi-Sectoral Strategic Framework and community engagement, particularly community-led monitoring, is one of the pillars of the implementation of the framework for the next 5 years. Again, we work together with the Ministry of Health and other implementing partners and participated in the review of the National HIV and AIDS Health Strategic Plan for the next 5 years. And it includes also community-led monitoring as one of the structures, one of the approaches that the government will implement to ensure communities are participating in the improvement of quality of services. So this is the plan we have, and it's based also on the structure and the systemic change in the country. Asante.
Let's do two. We'll do right here, we have with the mic, and then we'll go to the back, and then we can continue the conversation over drinks and canapes.
Okay. Thank you so much. My name is Matthews Chavunya. I'm from Malawi. We're implementing a similar intervention under MANASO, which is the Malawi Network of AIDS Service Organizations. So I wanted to understand a few things which I think we can learn from. In Malawi, we have a number of tools that we're using because we understand the community has some subpopulations. For example, key populations, which can be divided into female sex workers, men having sex with men, etc. And we also have the adolescent boys, adolescent girls and young women whose needs are different from maybe the population at large. But guessing from the presentation that have been made here, I understand in Tanzania only using 2 tools to collect data, as well as in Burkina Faso and the other country, which I failed to pronounce. So I wanted to understand, to say, with only those 2 tools, are you able to collect data in all those varied subpopulations? If yes, how do you make sure that the data that you are collecting, you are confident that it really has an input from all the subpopulations, because they're just 2 tools? I just wanted to learn from that. Thank you.
Thank you. We have several tools. What I presented is a project activity which was initially using the questionnaires. Questionnaire for health staff, but also questionnaire for service recipients. But also recently we have developed scorecard and focus group discussion tool to kind of increasing the number of tools based on the communities. And we are actually contextualizing and adapting the tools based on the group that we are going, which is going to be involved in terms of data collection, but also in terms of the feedback. For example, recently we received support from UNICEF to develop the AGYW training package and data collection tools for CLM. And I think by end of January, it will be out for use by other partners. So the tools are not static, but we are regularly reviewing them based on the type of group that we are involving in terms of data collection, but also the information that we need to collect from the communities. Thank you.
Okay. Il faut dire qu'au niveau du Burkina, nous ne doutons pas du tout de la fiabilité des données collectées, parce qu'elles sont faites à partir des agents de collecte qui ne sont autres que des conseillers qui travaillent habituellement avec donc, les personnes vivant avec le VIH dans ces différents sites au Burkina. C'est dire que ces agents de collecte sont permanemment en contact avec les personnes vivant avec le VIH. Alors,
Vous pouvez recommencer?
OK. Je disais que nous n'avons pas de doute sur la fiabilité des données que nous collectons.
We are pretty sure and pretty certain about the quality of the data that we collect
Parce que nos agents de collecte ont été identifiés
because the agents on the fields have been identified beforehand,
parmi les conseillers, les médiateurs sociaux
and they are among the peer educators and the social mediators
qui travaillent déjà donc en accompagnement des sites qui offrent les services au profit des personnes vivant avec le VIH.
that are working with people living with HIV and are providing the services to these communities.
Et la collecte des données s'est faite dans le respect de la confidentialité, de l'équité.
Data collection is happening with confidentiality and anonymous procedures.
Donc, de sorte à ce que, en tout cas, ce que nous avons comme données soit vraiment issu d'une expression spontanée des clients, des bénéficiaires donc, des différents sites.
So the data coming out of the field collection is coming from a voluntary effort. It's not forced.
Et il faut dire que notre collecte s'intéresse à toute personne, aussi bien, je veux dire qu'on a même impliqué les représentants des populations clés.
Our data collection involves everyone, such as the representatives of key populations,
Exactement, de façon à ce que vraiment ce que nous avons comme données ne soit pas biaisé du fait de la rétention de l'information au regard donc, de la discordance donc, entre les personnes qui répondent aux questions et celles qui posent les questions.
and we're trying to have as much as possible data that is not biased regarding disclosure and serological status of the
Voilà.
clients.
Et leurs représentants sont dans notre comité de suivi et ils s'assurent que les données émanant donc des sites reflètent leur vécu, leur réalité.
So the representatives are in the M&E committee, so they are the ones making sure that the data is true and authentic. It represents the data coming from the community.
Et sur leurs recommandations, nous avons procédé à la révision de nos outils pour mieux prendre en compte leurs besoins.
Under the suggestions and recommendations, we have reviewed our tools in order to take into account their needs.
Merci.
Thank you.
So I will try to be very quick since we are out of time. In order to make sure that we go with the needs of each key population group, we decided that our method for data collection will be quality data collection, and the tool is in-depth interviews. So whenever a person, our beneficiary, has the need to tell us about something else, something that is not in the questionnaire, the format of our data collection allows us to do so. We have 3 key population representatives in our CLM team because the epidemic in our country is mostly concentrated among key populations. And it is very important that all 3 key populations are represented in the team, because when the interviews are conducted, we make sure that, let's say, a person living with HIV collects data from other people living with HIV, and as this person openly says about his or her status, and it creates this trust and connection between the beneficiary and the interviewer. And it's not an easy thing in our country because we do not have a lot of people living with HIV with an open status. It's kind of a difficult task to find someone who is willing to openly say, hey, I'm also living with HIV, so let's talk about it. Let's make sure that we are on the same page, that we understand each other. And the same goes to other key population groups. So when the interview is taken from people who inject drugs, we make sure that the interviewer comes from the same population group. And this is our method to make sure that their needs are taken into account and that they are not left behind.
Great, thank you so much. Unfortunately, we're going to have to end the session. We can continue these discussions. Once again, applause, thank you. And I do just want to highlight that you can see the impact that CLM can have across many different areas. The mention of how it's educating people on their rights. It's not just one activity to gather data. So what we will be doing is organizing more events around CLM. We want to invite you to participate in quarterly calls that we are organizing alongside UNAIDS. There will be events regional that we're working with a global fund, more tools. There is right now a huge push for the development of tools and in various languages, including Russian, French, Portuguese, Spanish, and English. And right now what we are seeing is a growing interest in CLM. It's really going to help meet for PEPFAR this goal of the 50% of engagement, of making sure that there's community leadership, but also for the communities that we're building and integrating a process through which they can truly be heard. So thank you.